of the viscoelastics or intraoperative distortion viewing of the instruments in the anterior chamber seen through tapes, cone in the catacombs during phacoemulsification, and multiple studies in cataract surgery of catacombs patient has been seen that clear corneal incision are safe and do not need any suturing itself. Post-operative challenges, very few studies or reports have highlighted management options for residual refractive error in catacombs patients, and residual refractive error is common. Conclusion. Apart from the usual preoperative consideration of corneal parameters, IOL calculation due important may be given to status of zonules. Literature does not show any report of associated zonal weakness in eye with keratoconus. Hence, it is important to be prepared for possible zonal weakness in such eyes. My limitations are, it is a single case report and is not able to draw a correlation from our study. Hence, we need more data dealing with cataract surgery in keratoconus. We plan to go through evaluate all eyes with keratoconus for signs of zonal dialysis preoperatively and intraoperatively a regular follow-up so that we can study if a correlation or if there is an association. These are my references. Thank you.
Thank you, Dr. Soumya.
I do use a very gentle method of hydrodissection, and nucleus rotation I use a 2-instrument method usually, so that the zonules won't be in a tensed manner. Then I go for a phacoemulsification in a very slow process. We can use it and everything will be difficult if I use it before I get rid of the caps, cortex and everything. So I use after all that, and then a gentle pushing of the into the CTR will be placed, and then after I put the IOL very gently. Even also for the hydration also I will be more careful, so that the last step even it will not be a simple method. So it's a keratoconus patients. The IOP.
Since your case was of a keratoconus patient with pre-existing zonal dialysis, it could have focused on the case rather than a review of literature of ILFR calculation. What you're saying now should have been highlighted in the...
Yeah, I do have a presentation video, but I couldn't bring it up. I had a case, I had done this case myself,
yes.
So I had a video. Actually, it was not working. That's why I couldn't put it in this.
Because you could not see the
case. Yes. Pterygium in presence of at least one diopter of cylindrical astigmatism were included, operated by 3 consultant surgeons of at least 5 years of experience. All patients who had recurrent pterygia or any other causes of pterygium with oblique astigmatism and who didn't have 1 month of follow-up were excluded in this study. Out of 255 patients who underwent pterygium surgery during that period, 122 fit into the inclusion criteria and they were selected. The initial demographic details, best corrected visual acuity, subjective refraction, grades of the pterygium, presence of cataract and any keratometric readings using the Hewitt's autokeratometer HRK 7000 were collected during the preoperative, postoperative 1 week and postoperative 1 month. This is the grade of pterygium which we use in this study. Just crossing the limbus is grade 1, grade 2 limbus 2 up to the pupillary margin. Encroaching upon up to pupillary margin was grade 3, and double-headed monoocular pterygium where there was a pterygium in the same eye nasally and temporally. With the rule, astigmatism was described in the study as 90 degrees plus or minus 30 degrees, and against the rule was described as 0 or 180 degrees plus or minus 30 degrees. Stability of astigmatism was considered when there was no change or change less than 0.25 diopters between 2 successive follow-up. The statistical analysis was done using the R software, and p-value less than or equal to 0.05 was considered as statistically significant. Appropriate statistical tests were applied for the analysis. The mean age of presentation was 55.16 years, and 90 patients, that is 73.8%, had outdoor activity as an occupation, probably due to the prolonged UV light, which is the causative agent for the pterygium, as described by other studies which was done in South India with tropical climate. Majority of the patients presented with grade 2 pterygium. Around 86 patients had grade 2 pterygium. In our study, we found that magnitude of astigmatism proportionately increased with increase in grade of pterygium, as in the double-headed monoocular pterygium here had a maximum astigmatism of around 9 diopters. We also found that 75 patients in the study had with the rule astigmatism, and then which became against the rule or neutral at post-operative 1 week, which was statistically significant. 44 of our patients had cataract with pterygium, and upon excision there was significant change in magnitude and type of astigmatism. This was the, you can just see the central 3 mm myos is affected with pterygium with cataract. On excision, it almost stabilizes immediately. Also, there was visual acuity was 0.44 logMAR at presentation preoperatively, which statistically decreased, which reduced to 0.37, which was statistically significant. In our study, we also found that the mean preoperative astigmatism was 3.31, which statistically reduced to 1.05, which was also significant. Upon subclassifying the study, we found that in grade 1 pterygium, the stability was achieved at 1 month, where there was no significant change between 1 week and 1 month post-op, where in the higher grades, there was significant change in the keratometry readings 1 week and 1 month post-op. So we would just, I would just try to say the most common type of astigmatism is with the rule astigmatism associated with pterygium. And also on successful removal of pterygium, there will be improving visual acuity. I would also say the keratometry was not stabilized at higher grades at the end of 1 month post-excision, and there was a study done in Thailand by Dugatran et al. Which demonstrated minimum 3 months was required. The drawback of a study is it's a retrospective study, and we had to exactly determine the exact time taken for the stability of the keratometry. So here we used autokeratometer, which measured 3 mm of the central cornea, which is most important in biometry or IOL power calculation post pterygium excision combined with cataract, as many of our patients had cataract with pterygium. Thank you.
My presentation.
Yeah, there were granulomas, suture granulomas, but that didn't affect the keratometry reading. And there was graft edema in this grade 3 and grade 4, which was like in the ARR. Only like 3 patients had graft edema, and suture granuloma was there in 4 to 5 patients. Yeah, that has.
Any evidence of any graft was just extrusion of the graft?
I have not included those cases in the only CAG, which was they were all graft necrosis or whatever displacement.
One of the common problem we face is the retraction, right, on the intended side. So, do you have any problem with that? Graft retraction.
From the cell. If it is there, if it is noticed in post-op 1 week or immediate post-op, I would just do regrafting.
How did you rule out irregular astigmatism? You're saying it caused flattening, of course, with irregular astigmatism.
I took only that is another I have taken. Only ARR, which measures only central 3 mm. That is the only instrument I have taken, and this is a retrospective study. But I would want to do a topography just to see where the flattening exactly, like if it is grade 1, definitely central 3 mm, as I showed that 3 mm is not affected in that. Only the peripheral myos will be affected, which will just cause an HOA, a higher order aberration, and might not actually affect the visual acuity in the center. But higher grades, as I told, grade 2, grade 3, or even this double-headed mono, they affect the central myos. The one case where I showed the central myos was affected in grade 2 with cataract. So in such cases, I would do the pterygium excision, wait for the central 3 mm at least to get a regular myos along with the keratometric stability of 0.25 diopter, then go ahead with the cataract surgery. The standard rule what we follow is like wait for 4 to 6 weeks post pterygium excision and do a cataract surgery. But when I was doing this analysis, I just found out we can't apply it for all the 0.25 diopter changes. Thank you.
We now call Dr. Zena for her paper on variations in the...
I'm here to present study on variations in the central corneal thickness during the menstrual cycle in Indian women. Nil financial disclosure. Introduction. The menstrual cycle in women has fluctuating hormone levels. LH receptors are found in ocular tissues such as the cornea, iris, ciliary body, lens, conjunctiva, lacrimal and meibomian glands. These hormones can increase the central corneal thickness by water retention in the corneal stroma, increase in intraocular pressure during the menstrual phase, influence tear film production and stability. So the aim of the study was to determine the variations in central corneal thickness during menstrual cycle in Indian women. Materials and methods. This study is prospective observational clinical study done in Regional Institute of Ophthalmology and Department of Obstetrics and Gynecology, IMS PHU. Number of subjects were 126 and they were followed up for 3 years, and it is ethically approved. Inclusion criteria: women between 18 and 45 years of age with normal menstrual cycle. Exclusion criteria: previous history of eye surgery, conditions affecting the central corneal thickness such as keratoconus, scarred corneas, dry eye, history of infertility, polycystic ovarian disease, pelvic inflammatory disease, contraceptives use, breastfeeding and diabetes mellitus. We screened 735 females, out of which 163 fulfilled the above criteria. 37 of the females refused to participate, so study was done on 126 females. Self-reported dates of the menstrual cycle by the participants were noted. Ovulation time was confirmed by the luteinizing hormone level. LH values of 25 to 30 international unit per liter was taken to confirm the ovulation within 24 hours. A complete ocular examination was done to rule out any ocular abnormality. Central corneal thickness was measured by an ultrasound pachymeter, that is Tome SP300 pachymeter, within consecutive 3 days in all 3 phases. Data were analyzed by SPSS version 20. In the results, what we observed, the mean age of the participants was 26.6 plus minus 2.6 years of age. The mean duration of the cycle was 27.9 plus minus 2.9 days. In 92% of women, central corneal thickness changes were seen, while in 8% there was no difference between any phases of the cycle. The mean central corneal thickness of both eyes were 541.76 plus minus 4.21 micrometer at the start, 559.21 plus minus 4.50 micrometer in the middle, 544.52 plus minus 8.06 micrometer in the end of the cycle. So in this table, what we have done, we have assessed the mean central corneal thickness of the right and left eye in micrometer in different phases and entire menstrual cycle. So here we have applied the unpaired t-test, and what we saw, it is not statistically significant in beginning, middle and end, and in entire cycle. The right eye and left eye has the same, almost same central corneal thickness. But while comparing of the mean central corneal thickness of the right and left eye during the different phases and utilizing the paired t-test, what we saw in the left, right and over all of the cases, between the beginning and middle and end, and beginning and end, in all the different phases, what we saw, it was statistically significant. The difference in central corneal thickness was statistically significant. Discussion part. Fairman et al. And Soni, the lowest central corneal thickness just before ovulation and maximum at the beginning of the cycle. Kylie et al. Said the cornea was thickest at the time of ovulation. Faruqi et al., he concluded the cornea was thickest during ovulation time and thinnest at the end of the cycle. Our study states the cornea was thickest at mid-cycle followed by the end and beginning of the cycle. The conclusion, the CCT value was significantly higher during ovulation compared to the beginning and end of the menstrual cycle. So our study recommends that menstrual history may be included in the workup of females undergoing refractive surgery, IOP measurement, contact lens fitting trial. Limitations of the studies are also there. The stages of the menstrual cycle and follicular maturation were not verified by abdominal ultrasound. LH levels during all the phases of the menstrual cycle were not measured, so correlation between central corneal thickness and LH levels was not possible. So we could not explain which layer of cornea is responsible for changes in central corneal thickness as we used USG pachymetry. These are my references. Thank you.
Found in refractive surgery. So how would the decision making change in patients undergoing refractive surgery based on the changes observed? What is the clinical significance?
Clinical significance is like what we concluded in our study in Indian women. What we saw, there is stromal edema. Due to that, there was increase in central corneal thickness. So, if there will be variation in the central corneal thickness, so whatever surgery we will plan, it may affect we can get the post-operative surprise in the patients. So for that we
Which
have,
phase would you recommend to perform the surgery?
ma'am, in the beginning or in the end of the cycle, probably we will ask the female for the central cornea thickness for the measurement.
Why?
Ma'am, because in the what we saw in our study, in the luteinizing during the LH surge, 3-4 days, the central corneal thickness got increased. So it may affect the post-operative surprise. We can get post-operative surprise in patients. So we will definitely suggest
It's a research question.
this is a research question, ma'am, but in our study it was according to our study.
We now call upon the next speaker, sutureless, glueless pterygium surgery, the autologous blood method by Dr. Ankit Agarwal.
For giving this wonderful opportunity to present this study. The topic is sutureless, glueless pterygium surgery, the autologous blood method. Pterygium is an overgrowth of epithelial limbal tissue over the cornea in a usually wing-shaped pattern. It occurs mostly on the limbal side, nasal side, but can occur elsewhere too. The most common risk factors include UV exposure and outdoors work, thus it becomes very prevalent in India and other tropical countries because the patients here are frequently exposed to dust and UV light. Now the types of pterygium surgery grafting include no graft, that is Bayes-Serra method. This was the original method used, but it has a recurrence rate of more than 50%. Then there came amniotic membrane graft, which is a very good method, but now it is mostly reserved for cases with recurrent pterygium. And the most recent and the current method is autoconjunctival transplant, where the conjunctiva from the same eye containing healthy limbal stem cells is transplanted upon the Bayes-Serra from where pterygium has been removed. This was first described by Kenyon et al. In 1985 with a recurrence rate of less than 6%. Now the methods of autoconjunctival graft fixation include sutured autoconjunctival graft, glued autoconjunctival graft, and the latest technique which I am describing here, that is the autologous blood fixation. Now the purpose of this study is to describe a sutureless, glueless conjunctival graft fixation method in pterygium surgery. It was conducted in an eye hospital in North India. The number of eyes were 34, which were done during May 2023 to April 2024. That is a 1-year study. Now first, the pterygium is excised by a normal method. That is, the surgeon can have their own preferred method. Many people use a crescent, many people use scissors, but I prefer to use forceps to pull it out of the conjunctival area. Now I use a crescent to shave it out. The head area is shaved out from the cornea. The subconjunctival tissue, which is exactly the pterygium tissue, is removed. Leaving the conjunctiva above it. Now using a corneal burr, I'll just remove the remnant area and try to smoothen the cornea. An approximation of the size of the graft is done. And graft is taken from the opposite side. I try to take graft from the temporal side, not the superior side, because I try to leave the superior side for future surgeries like trap or SICS. Anyways, phacoemulsification can be done clear corneal, so there is no need to have a conjunctival graft from that side. The graft is fully excised properly and is put over the sclera. making sure that the limbal side stays on the limbus and the temporal side is similar. The graft size is taken slightly bigger than the pterygium and the underlying edges are tucked inside so that it doesn't move in the post-operative period. Now I wait for another 5 minutes to let the graft sit there. So autologous blood method of graft fixation gave wonderful results, and the patient in all patients, and the patients were followed up for 6 months, had minimal recurrence. In fact, I did not find any recurrence in any of the patients. It's a wonderful cost-effective method, can be used because it uses fibrin from the patient's own blood as an adhesive. Thank you.
What was the inner thickness conjunctival autograph or a full thickness? Because I could not see you delineating the tenons from the superior conjunctiva when you were harvesting the graft.
Yeah, in this case which I have shown, I have taken a full thickness graft, but in majority of my cases what I have done is that I have used a normal saline to in the subtenon areas to make the tenon and
It will
conjunctiva
not
separate.
be subtenon, it will be subconjunctival.
Sorry, subconjunctival area, so that to separate the conjunctiva from the tenon and take the conjunctiva only and remove leave the tenon there.
So in the full thickness, are you saying that you had no graft contraction and scarring? Because full thickness graft is not going to stay, it is going to contract because there is fibrous tissue. It's not possible.
That's what I'm saying. Mostly I have taken all the only conjunctival grafts. This is the video which was actually the most clearest, so I showed this, but actually in this video I have taken the full thickness graft. But I really did not find much contraction even in this case because
Do you have post-operative serial photographs?
no, I don't have right now.
The documentation would be required when you make such a claim.
One more comment. You have not done the complete keratectomy in your patient. Is it complete keratectomy was done, or we had some knowledge?
I removed the pterygium part from the cornea and as much as possible I smoothen it out.
Is there any instance of any recurrence in your patients?
None in my cases. That's what 34 cases I have done in 1 year with this method, and I did not find any recurrence amongst in 6 months follow-up for each patient I have done.
Thank you.
Thank you.
All the presenters and the judges, please.
Sir? Yeah, sorry. Now, you need to search for this.